Hello friend, welcome to my channel 5 Minute Pediatric. Today we have a special guest. We have Dr. Prachi ma'am. She is DM Neonatology and consultant at Mahavir Vasalya, Patna. She will be discussing about PDA, which PDA is treatable, which PDA we should treat and which PDA we should not treat. So over to Dr. Prachi ma'am.
ठीक है, ठीक है. Thank you, Dr. Amit, for introducing me and calling me to your popular YouTube channel, 5 Minute Pediatrics. And today I'm Dr. Prachi, and I'm here to discuss a very, very controversial topic of neonatology, about which there are still no international guidelines, and all units are using different policies. And the topic is patent ductus arteriosus, and the question has to treat or not to treat is still unanswered. So it is a short topic of discussion of all the controversies and what we should do. So first, this my talk is based on few questions in PDA, like what is PDA, why to treat this PDA, which one of the PDA to treat and which one not to treat, how to treat, and when not to treat PDA, and what our unit is following in here in Patna, and also what big units or famous units of India are following currently. So we all know the problem of patent ductus arteriosus is a problem of prematurity. And what is first, just a short introduction, what is a patent ductus arteriosus? We all know the ductus arteriosus connects the aorta to the pulmonary artery, while in the fetal circulation, it is beneficial, very beneficial for the fetus, because it takes blood from the aorta and from the pulmonary artery in the lungs and gives it to the aorta. And this is actually the main blood supply of the whole body in the fetus. However, once the fetus has come out of the mother's womb, there is dynamic changes, there is cord clamping, and ideally this ductus arteriosus should close within 24 hours. Now, in term babies, mostly it will close by itself. The problem comes with prematurity, and in today's world, prematurity has become a big problem. We all are facing preterm babies. So in term and preterm units of more than 1500 grams birth weight, the ductus almost spontaneously closes within 96 hours of birth. And it does not create much of a problem. However, when we are dealing with babies who are very low birth weight or less than 1500 grams, it is a substantial problem in our NICUs. So we are up to 24 hours, it is physiological. After that, if it persists, which is common in premature, because the muscles of the aorta of the premature baby is not very sensitive to oxygen like it in a term baby. So in term baby, once it gets exposed to oxygen, the ductus arteriosus muscles start contracting, smooth muscles, and it closes. But in preterm, the muscles are not properly developed, so it does not close. Now, after 24 hours, it starts leading to symptoms and problems in premature babies. Now, there are some things which are important for us to know, that echocardiography will detect an open ductus arteriosus 48 hours before a murmur appears. So, in units where there is facility of echocardiography, do not wait for murmur or clinical symptoms to appear. And hence, nowadays, echocardiographic screening of babies less than 1500 grams after 24 hours, and then once every 24 hours up to day 5 of life is recommended. Okay, so this is what a patent ductus arteriosus does. In the fetus, we have seen it behaves like a right to left shunt, and it helps the fetus to get the maximum amount of cardiac output. However, when the newborn baby, once the systemic vascular resistance has increased, it converts into a left to right shunt. That means blood starts flowing from aorta to the pulmonary artery. So what will happen now? From the left to right shunt, from aorta to pulmonary artery, there will be increased pulmonary blood flow. There will be venous congestion in the lungs. There will be compromised right ventricle and pulmonary artery coupling, and it will lead to one devastating effect of patent ductus arteriosus, which is pulmonary hemorrhage. Apart from this, because of overload in the right ventricle, there will be left ventricular dysfunction, then coronary artery ischemia. Again, there will be myocardial ischemia, and there will be both left ventricle and right ventricle dysfunction in these babies. So we can see the pathophysiology of PDA in these slides. Now, the important question: why should we treat PDA? There are two major consequences of a patent ductus arteriosus in a preterm baby can be disastrous. The first thing is it will lead to poor pulmonary overcirculation because of a left to right shunt, and there will be, because of that left to right shunt, excess blood flow is going to the lungs. So all the lungs in the systemic blood flow has reduced. So there is combination of pulmonary overcirculation and systemic hypoperfusion, which manifests like prolonged ventilation, pulmonary hemorrhage. It is also a huge risk factor for bronchopulmonary dysplasia, NEC, renal failure, intraventricular hemorrhage, and later on it also has been implicated in various studies as a prominent factor in developing cerebral palsy in preterm babies, and it has also huge mortality if not treated on time. So we should treat PDA. Now there's a big question: which of the patent ductus arteriosus should we treat? Now, defining hemodynamically significant PDA, or HSPDA for short. Till date, no international body has defined HSPDA in clear terms. We all are using one consensus of findings, which consists of both echocardiography and clinical findings to define and treat is a hemodynamically significant HSPDA or not. So how will we define it? So now one thing is clear: we should always treat a hemodynamically significant PDA except in one or two conditions, which I will discuss later. And if the PDA is not hemodynamically significant, we may leave it. Now, this HSPDA, I have all over the world, there is no uniform definition. However, these echocardiographic findings and some clinical findings will help us define an HSPDA. In the echocardiography, if the ductal flow we found as more than 1.5 millimeter, if we take the left atrium and aortic ratio of in the posterior longitudinal axis view more than 1.5 centimeter, if the cardiac output our pediatric cardiologist has written to be more than 320 ml per minute per meter square, and we find absent flow in descending aorta, these are echocardiographic findings which are suggestive of HSPDA. For all the viewers who are not working in a unit with an echocardiography, you can suspect an HSPDA when there is no other reason and still the baby is having increasing oxygen requirements on day 2. Now, baby should lose at least 2 to 3% of its birth weight from day 1 to day 10 and then regain it around by day 14 in a preterm baby. However, if there is a patent ductus arteriosus, this weight loss will not occur, and instead the baby may start gaining weight. Then there is suddenly poor color, prolonged capillary refill time, poor urine output. These are all signs of systemic hypoperfusion due to PDA. Then an increased pulse pressure, the systolic minus diastolic blood pressure of, if the difference is more than 25 millimeter of mercury, and pulmonary hemorrhage. There is a huge constellation of other findings also, but these are the most common ones. So if we are finding a combination of these findings in clinical findings or echocardiographic findings, we define it to be a hemodynamically significant PDA. Now, these are slides of echocardiographic findings of patent ductus arteriosus. PDA is best seen in a short axis view where the pulmonary artery is dividing. See this is the pulmonary artery, the root of the pulmonary artery dividing into two parts. And this is the third branch, which is actually the ductus arteriosus, which is patent. Then in this slide, when we put color here, then this actually the blood should be flowing from the pulmonary artery into the lungs, which is the blue color. However, if the ductus is patent, there is a red flow opposite direction from the aorta to the pulmonary artery. So this is very, very suggestive of a ductus arteriosus. And here we can put the cursor and take measurements right where the ductal constriction is seen. And if this is more than 1.5 mm, almost maximum places are using the criteria of 1.5 mm, then we think it to be a HSPDA. There are these other figures also. See, this is normal. This is a closed ductus arteriosus. Here is the main pulmonary artery dividing, and this is the ductus arteriosus. Now, in this figure, it was blue. However, in place of if it is actual PDA present, this becomes red. So in the other side, this slide also, you can see that this patent ductus arteriosus is an opposite flow from the aorta to the pulmonary artery, which is red in color. Then this is one another view of determining which is the most common view, criteria used currently. In the posterior longitudinal axis view, we see the left atrium, left ventricle, aorta, and then we put the M mode and we try to measure this ratio, left atrium to the aortic root diameter. And if it is more than 1.5 mm, that also is a significant that our left atrium has dilated due to pulmonary overload, which is significant for the PDA. That means we are dealing with a hemodynamically significant PDA and it needs to be treated. Okay, so once we know what is an HSPDA, and now we have to treat it. Now, what are the drug options currently which we are having? We have two options. Earlier, there was injectable indomethacin, but most units have not been using it anymore because of risk of renal failure and thrombocytopenia. Currently, according to the latest Cochrane reviews in 2020, the safest drug, and which is now being widely used also, is injectable or oral paracetamol at 15 mg per kg per dose, 6 hourly. And the second drug is oral ibuprofen, 10 mg per kg stat, followed by 2 doses of 5 mg per kg per day, 24 hours apart. But with ibuprofen, we have to check the renal function and platelet counts before starting ibuprofen. And it has to be avoided if RFT are deranged and platelet count is less than 1 lakh. So these are the two options, paracetamol definitely being safer, and ibuprofen, lot of units consider it to be more effective. But still, the superiority of ibuprofen has not been proven over paracetamol. And then we come to, apart from these two drugs, which we will start, what is the supportive management in a case of patent ductus arteriosus? First thing is fluid restriction. Since it is a left to right shunt, we have to keep the total fluid intake of the baby on the lower side, around 100 to 110 ml per kg per day, whatever be its day of life. Then usage of slightly higher PEEP in some studies has been shown to helpful in closing the patent ductus arteriosus, and keeping the systemic pressure slightly on the higher side using inotropes like dopamine has been shown to decrease the shunt volume. Then upon these, there are some reasons which will interfere with closing of your PDA, that is like sepsis, and we should keep that under control while trying to close out patent ductus arteriosus. Then now since it's a small talk, I will tell you there are some conditions where, although there is a hemodynamically significant PDA on echocardiography, but we will avoid treating that patent ductus arteriosus. Especially, it's a very, very common condition is PPHN, or primary pulmonary hypertension, which is commonly seen in patients with asphyxia. Now, if there is a case with severe PPHN, your cardiologist or a neonatologist trained in functional echo will come and tell you there is severe PPHN, there is a huge TR jet, and the PDA has become right to left. In this condition, when the PDA has the pressure of the pulmonary has become so much, pulmonary venous area, that it has become suprasystemic. It is more than the systemic pressure. There, this PDA helps to debulk the excessive fluid from the pulmonary circulation into the systemic circulation. So in this condition, PDA does not have to be treated. So, and if PDA is helpful for the baby in treatment of PTHN, so avoid treating, even if it is a HSPDA, its diameter is more, then do not treat in case of PTHN with a right to left shunt of PDA. Then the next condition is duct-dependent congenital heart lesion. We know there are many congenital heart lesions which are dependent on PDA for their systemic flow, like PAPVC, tricuspid atresia. The pediatric cardiologist will come and diagnose these conditions, and in that condition, that they will give you a suggestion that we have to keep it open, keep the PDA open till any surgical procedures like atrial septostomy can be done for these patients. So that time we have to keep it open using prostaglandin E1 infusion. So in that case, do not make the mistake of trying to close the PDA. And the third is, if it is a small closing, non-hemodynamically significant PDA, we do not need to give burden to the neonate of using drugs like ibuprofen or paracetamol. This PDA, if it is not disturbing the patient, it is clinically silent, it will close by its own. So it should not be treated. So it is a small, this is the unit protocol which is being used in maximum units of India, and our unit is also following. We are screening all babies less than 1500 grams for patent ductus arteriosus at 24 hours of life using echocardiography. If we detect an HSPDA on echo, and even if it is currently clinically silent, still by our unit protocol, we are treating using injection and oral paracetamol at 15 mg per kg per dose, 6 hourly for 3 days. Then we do a review echo after 3 days of paracetamol. If it is still persisting and if there is clinical symptoms, so we give a repeat course of paracetamol for 3 days. And still, if we are doing echocardiographic monitoring, still not closed, then we are using oral ibuprofen for 3 days. And more than 95% of these babies we have seen to be responding to this regimen. And if the baby is still on having HSPDA despite not responding to oral ibuprofen and 2 courses of paracetamol, we continue and conservative management and plan for surgical ligation, although this facility currently is available in very few units in India. So we have to refer the patient. Now, this is a simple unit protocol for units who are not having echo facility, because still in peripheral areas, echo is not routinely done in NICUs. So in these cases, what we should do is, we should, from day 2 of life to day 5 of life, we should be very careful about the appearance of patent ductus arteriosus in the babies. And we should have, clinically, we can make an early judgment if we do a daily weight of this patient. We can see if patient is not having any sepsis, still suddenly the FiO2 or the oxygen requirement on CPAP or ventilator, whatever we are using, that suddenly the oxygen requirements are increasing. Patient is requiring 50-60% of oxygen. Patient is having sudden episodes of apnea, which are unexplained by any other reason like sepsis. And there is decrease in urine output. It may not be less than 1 ml per kg per day, but it has slightly decreased. Now, from day to day 5, if we are very alert, and clinically, if we are auscultating for murmur, and we find a systolic murmur on the left side of chest, it is highly suggestive of PDA. Many times you may not find the murmur, but these other clinical findings are suggestive, then it is a suggestion to treat with paracetamol or ibuprofen. And the important thing is, a PDA in a bigger child or in a pediatric group will present like a pansystolic murmur. However, in a neonate, it will present like an ejection systolic murmur on the left side of chest, and it is not found to be pansystolic. Then if we are clinically suspicious, we can treat the patient with paracetamol or ibuprofen, and then go ahead, like and still not responding, then we can plan for surgical ligation of these babies. So I hope I have answered few important questions about patent ductus arteriosus. Thank you very much, Dr. Amit, and thank you all of you for listening to me for this while.